Hey guys, this is first week lecture topic on technique charts, AEC and APR. You can find relevant materials on those scattered across 3 chapters of Bouchon. Yes, I'm sorry. A little snippet in chapter 6, a little bit more in 15, and then most of the material from chapter 16. Okay, so our objectives, excuse me, give me just a second. Our objectives, advantages and disadvantages of our 2 different methods of developing technique charts. The proportional anatomy strategy, which I think I already explained to you when we first talked about technique all the way last year at the beginning of radiographic procedures. Examples of proportional anatomy application, and I do have some of those on that slide. How do you build a technique chart, which is an obsolete process, but they make me go through it, so I'm going through it. Advantages of the hybrid model, which is probably the most practical information regarding technique charts given to you in this unit. Okay. Components and operations of an AEC system, that's part 2 of our lecture. The terms related to AEC, backup mass, minimum response time, density controls, and other terms. Automatic rescaling, so we're going to jump ahead and steal a topic from digital imaging that you haven't had yet, and that is the automatic rescaling software system and how that works as an antagonist to the AEC density button. Common causes of overexposure and underexposure when utilizing AEC, and so a little bit of troubleshooting, heavy registry content through that troubleshooting section. Okay, and also I would peg registry content with the definitions of terminology related to AEC technology and the problem solving. I used AEC and it radically underexposed. What went wrong? I used AEC and it seemed to overexpose. What went wrong? And so some of the common pitfalls of using AEC will be explained near the end of the lesson. Okay, and then finally, the replacement for technique charts in the modern era, the anatomically programmed radiography and utilization of that, and you're already familiar with that. That's the menu button where you say, I want to shoot a chest PA at the wall bucky and I want to use the outer cells, and then this patient is hypersthenic habitus, and you mash all that on the control panel and it says, why not use 120 kVp with the outer cells engaged and a backup mass of 600 mass? And you say, thank you, computer, that's a splendid idea. Yeah, that's APR. All right, so real quick, benefits of standardization, and kind of like a crucifix for a vampire, making you recoil in horror. You thought you were done with that. No, you are not. That is the control panel section of the X-ray schematic that you learned in physics. So just a quick reminder, when we're setting technique, that's setting KV, we're manipulating the autotransformer, secondary side, and when we're setting MA, we're manipulating the rheostat. The timing circuit is controlled by quartz timing, which is the same thing that controls your oven in your kitchen. And it's the same way your cell phone keeps time. Okay. Alternately, your timing circuit is also wired to the automatic exposure control that runs in parallel to the timing circuit. And there's a selection for enabling and disabling automatic exposure control that I'm sure you're familiar with. Okay. Now, technique charts and, more importantly, consistency of technique. It's important because it leads to a consistency of image quality. Okay? And we know that there's follow-up radiographs, right? You break your ankle, you get immediate x-rays in the ER, and then they take you up to surgery, they fix it, and then they send you to the PACU, and then what happens? We get follow-up x-rays in the PACU. Wouldn't it be wonderful if the radiologist looking at the knee, the fractured knee in the ER, and then 3 hours later doing a follow-up read on the images in the PACU, or I'm sorry, the ankle, not the knee, doing a follow-up read, so the ankle before fracture repair, ankle after fracture repair, this happens every day. Wouldn't it be wonderful if those x-rays looked consistent in quality and they looked basically the same except for the addition of the hardware? Yeah, that would be great. That would make it much easier on my radiologists, that's for dang sure. Okay, and so that's the advantage of standardization. So what I'm saying is every technologist, or most of the technologists in the department, should be using about the same technique for about the same body part. Okay, and you can test this as a student, and you probably went through this experiment as a freshman student. What technique should I use? All right, and then you got 7 different answers. Was that confusing? You bet your butt it was confusing, and so now take a gander at number 3. Okay, when you're first trying to learn technique and what to set as a first-year student, and you asked, what should I use? Wouldn't it be nice if everyone gave you dang near the same answer? That would be a wonderful world. Now, thanks to APR, that's happening again. Okay, but there was a little bit of a wild, wild west when we started transitioning out of screen film and into digital radiography, and people were just making up stuff. Okay. But APRs have become more and more consistent, and the manufacturers recognize that the APRs are heavily relied upon for accuracy. And so for the most part, your brand new equipment has got really good APR pre-programmed techniques. Okay, and that helps shorten the learning curve about technique. Okay, so why do you choose that? Because that's what the computer recommended. That's just a different answer than that's what works, which is what the answer that I got when I say why do we use that back in the day. Okay. The other thing is when the equipment tears up, when it's not working, when your imaging system's not working right, either the X-ray tube is not broadcasting the beam, the KVP or the mass has fallen out of calibration, and so you're not getting the same beam as is advertised on the control panel, or something's wrong with the detector or the CR reader. Okay, it's harder to figure that out if it's a subtle loss of quality. Now, if it's a radical loss of quality, immediately you know the X-ray system is tore up and it needs repair. Okay, but if it's a subtle loss of quality, if everyone's not using consistent techniques, that subtle loss of quality kind of gets masked in the background and it lingers. It's affecting the diagnostic quality of the images, but no one's catching it because everyone's using such a wide variety of techniques. The radiologist is used to seeing like ankles and elbows and abdomens with different grayscale ranges and different, like just even the same patient looks different if Sam takes the x-ray versus Jared takes the x-ray versus Becky takes the x-ray. The x-ray, less so in the digital age, but slightly different with different techniques. Technique still influences the final presentation of the image or the final perception of the image. And so that variance and an inconsistency of technique can mask subtle flaws in the imaging system that could be fixed. Okay? And so it's easier to narrow down a potential repair or figure out that a machine needs repair when techniques are more consistent across all staff. All right, so if we are going to standardize technique, well, we need department standards for radiographic quality. Okay. Usually that's the radiologist. Back in the day, it was a QC technologist. But anyway, someone should be assessing overall radiographic quality. Okay. It should be, and it really should be the radiologist because they have to diagnose, right? And we know that poor radiographic quality leads to a loss in diagnostic information. So the radiologist should be involved in that. Every tube should have a unique chart. Now the APR has replaced the paper chart, but you might notice that the APR, that is the recommended technique spider machine, is not the same for the GE machine as it is the Philips machine, as it is the Siemens machine. Okay? And so each machine has its own techniques because each machine has its own generator. Okay? Fairly straightforward. Radiographic systems must be operating properly. Okay? That's one of the ways you're setting technique and you're shooting and you're expecting quality, and you get something different than that. Is this machine working right? Okay, and so your techniques are only consistent and only effective when the machine is operating as it should. Okay, part thickness measured accurately. Okay, and I'm required to tell you that the caliper is the correct instrument for measuring body part thickness, and you should measure it at the orientation of the central rays. So you see the red line passing through the inferior angles of the scapula. That's where the measurement should be taken, not the black dotted line at the bottom of the image receptor. Okay, part thickness through the middle of the body part is what should be measured. Okay. Technique charts, typically adjustments in technique charts are based on difference in, one of the primary adjustments is difference in habitus. Okay, and so when we started developing systems and standardization of techniques back in screen film days, we had two strategies: variable KV fixed mass and fixed KV variable mass. Okay. All strategies, all pre-published techniques, default techniques, if you will, even in APR, before you make any adjustments, the first technique that is suggested to you on the APR software is for average habitus. If you happen to come across a paper technique chart, those techniques are for average habitus. Okay? Or they might even have scaling for hypersthenic in the next column over. But typically the highlighted column or the primary column, possibly the first column for technique, is the technique recommended for average habitus, and the technologist is supposed to know how to scale up and down according to habitus. Okay, so with the fixed KV approach, again, this was for addressing film screen technology systems. Okay. These three things were true. KVP did assure sufficient penetration. KVP did control image contrast. Okay, that's no longer the case if you look at the bottom bullet point. Okay, and simplify and standardize for accuracy. It's really easy to make adjustments in the fixed KV approach because you just change exposure time. Okay. With digital imaging, contrast of the final image is not controlled by KVP, and so the fixed KV approach, one of the reasons for using it, is no longer present in the digital age. Okay. The fixed KV approach also has a fundamental flaw. You're going to overexpose your hypersthenic patients. Okay, so our advantages: it's very easy to use. Again, you only have to adjust the exposure time or the mass to change from one part thickness to the next. There's a consistency of the quality because there's a consistency of penetration power. Okay. Usually the fixed KV that you pick is adequate penetration even for hypersthenic habitus. Okay. Reduces patient dose, I would disagree with, because it does not reduce patient dose for all body sizes. It actually increases patient dose significantly for your hypersthenic habitus. Okay, so the fixed kV system is great for everywhere except for the South, because we better fry our vegetables down here. Yes, so we have our fair share of hypersthenic patients. That's a good way to say. Okay, we like our fried daddy deep fryers, don't we? I've got one. Yeah, I have occasionally deep fried a green bean. Yes, I confess. Okay. And so, but look at the mass recommended for the greatest part thickness on this chart, 120 mass. Now look at for the thinnest, 12. That's a 10 times increase in mass for the change, scaling the part thickness from 16 centimeters to 32 centimeters. You are multiplying the patient's dose by 10 for an increase of about 15 centimeters of thickness. There ought to be a better way. There is a better way. We'll get to that. Okay. The other strategy is, well, instead of an optimal KVP that overpenetrates for average habitus, but is optimal for hypersthenic habitus, let's scale the KVP with part thickness, because KVP controls penetration power. And so of the two older systems, this one makes more sense to me, because part thickness and KVP should scale, because KVP is penetration power. And so when the part thickness increases, you should increase KVP. When the part thickness decreases, you should decrease KVP. Yeah, it's just intuitive. If you understand KVP as penetration power, you understand it's easier to penetrate thinner parts. It's harder to penetrate thicker parts. So you should change KVP in proportion to part thickness. Yeah, could be more straightforward. Okay. The problem is if you're not an experienced technologist and you're developing KVPs and you're scaling KVP down, you can scale down too far. So everyone knows you can shoot a finger at like 50 kVp, okay? But in this strategy, you would be able to scale down a pelvis or an abdomen X-ray if your patient was small enough to 50 kVp, okay? That might be too far. You might not achieve adequate penetration. So you can scale beyond what's the minimum penetrative energy for the beam, okay? So you can scale down too much, and then you've underpenetrated, and then you have model. So that is a downfall, okay? The other thing is, with holding the mass fixed, you don't have the opportunity to save dose for your smaller patients, okay? So with the other strategy, you were overdosing hypersthenic patients. With this strategy, you're overdosing asthenic patients. All right, so here's an example of a variable kilovoltage chart. And you can see for that smaller part thickness, we're still dosing them with 100 mass. Not necessarily ideal, okay? I can see for sthenic habitus or hypersthenic habitus, at the far right of the chart, 100 mass might be appropriate for this particular, whatever this is trying to technique. But surely if the hypersthenic habitus is 22 centimeters thick and we've lost about 7 centimeters, we could achieve some dose savings if we scaled the mass down rather than scale the KV down. So I've revealed the flaws of both systems. So what should we do in the digital age? We should combine the two strategies into the hybrid approach. So the recommendation in the digital age is go ahead and spin up the technique on the APR. Tell the machine what you're doing. I'm doing a chest PA, okay? And if it's hypersthenic habitus, then let's increase KV. But if it's asthenic or hyposthenic habitus, well then let's decrease mass, okay? Both of those are going to save dose all across the spectrum of body part sizes and patient sizes. Okay, so it adopts the best of both of the strategies. Okay, the hybrid approach, whereas the thickness increases, we increase kVp. If the thickness decreases, we decrease mass, aligns itself the best with as low as reasonably achievable. Okay, and the strategy of the digital age is adequate signal, and so therefore adequate penetration, but not necessarily a robust amount of radiation. Our detectors are more efficient than they were in previous technologies, and so we can get away with higher kV, less mass across the board with techniques as a general rule. And we can also adjust techniques according to the hybrid approach, and we can realize a dose savings to our patient populations. All right, and then just as not really for developing, yes, you can use this to develop a technique chart, but this is really just a strategy to dream up of a technique on the fly if you need to. And it's very powerful. That it's called the proportional anatomy system, or proportional anatomy techniquing. And I have mentioned this idea to you before. Way back when we were first learning about technique, I said, you know that if you know an ankle technique, you also know an elbow technique. And that's because those body parts are basically the same size. And so the physics is consistent. The amount of kilovoltage you need to penetrate the elbow is basically the same amount of kilovoltage you need to penetrate the ankle, okay? Because the thicknesses are very similar, okay? Ankles maybe a little bit thinner, not significantly, okay? And so that's the proportional anatomy approach. If I know a technique for a certain size body part, I don't even have to be imaging that body part. I just have to be imaging something of a similar size, and I can use that technique. Okay. And so this is, look at that last bullet point. This is an extremely powerful tool for pediatrics, because I know for a fact I didn't teach you pediatric techniques, but I taught you a strategy for developing pediatric techniques. Okay, so 3-year-old, picture a 3-year-old, right? Tops out at about 35, 40 pounds, right? Okay, yeah, we're well fed here in America. 35, 40 pound patient, 3-year-old, okay? You're about to do a wrist x-ray on this 3-year-old, okay? Should you use an adult wrist technique, or should you use an adult finger technique? And I think you'll find if you're pressing your imagination, maybe smaller than a 3-year-old, maybe a toddler is more appropriate, but I think you'll find that an infant toddler wrist is about the same thickness, maybe as the hand, or maybe as a digit, depending upon the particular patient. But the point is you can just toss in adult finger technique or adult hand technique, and it's going to work on a toddler's wrist. Okay. Now that 35, 40 pound toddler, their abdomen is about the same diameter as an adult femur, right? So 18, 50 pound body weight. That's the example. Full term infant abdomen, 18 to 15 pounds birth weight. Okay. Pray for mom if it's a 15-pound birth weight, but that's a little aside. It's the same size as an adult femur, okay? And so can you use a femur technique? Yes, you can. I've done it. You can totally use a femur technique on a baby abdomen. Okay? If you don't know a baby abdomen technique, but you know a femur technique, well, by proportional anatomy, you know a baby abdomen technique. Okay. Oh, move ahead. Here we go. Okay. So special considerations. So the list here that we have, you should be assessing and you should be thinking critically. So if you're presented with these scenarios, morbidly obese patients, body parts in casts or splints or immobilizers, additive or destructive pathology like your emphysema, okay, or your bone cancer, or Paget's disease, or pneumonia, any of those conditions that we know are additive and destructive pathologies, you should be adjusting technique, scaling it up or down according to whether has the tissue thinned out, like emphysema, or has the tissue thickened, like pneumonia. And then the penetration power should scale with that. It's easier to penetrate an emphysemic lung than it is a healthy lung. And so you can actually scale the KVP back a little bit for the emphysemic lung. You're going to over-penetrate it, okay? Any variations from the conditions specified on the technique chart. Are you using the standard 40 inches? Even the APR, the technique that's recommended by the software, is assuming that you're using either 40 or 72. If you're using 55, that recommended technique is no good. You need to adjust with that mass compensation formula that Mr. Shepard taught you. Okay? Don't act like you don't know what I'm talking about. You know what I mean. What? We got to do math? Yeah. Okay? Unless you are always shooting at 40 and 72, which might be the case. Okay? But if you're using anything but 40, anything except for 40 and 72, that APR technique is off a little bit and it should be adjusted. Okay? Projections and positions. Okay? If you've dialed up a technique for an AP chest, but you're shooting it lateral, yeah, you see, look, I mean, if you're referencing a paper chart, you see the next entry down, see how it says chest lateral and those are different numbers? Yeah, that's for a reason. The body part thickness is doubled. Okay? Think about that. The linear distance from the sternum to the spine, right? 10 inches, 12 inches. Now turn the part sideways. Now we're dealing with like 20, 24 inches of depth of part thickness. So the part thickness is not the same for the AP projection as it is the lateral projection. So you should be changing technique as if the part thickness is changing that radically. Now, where can you get away with it? You can get away with it at the wrist and the elbow. And the forearm. The forearm really doesn't change thickness from AP to lateral. The hand changes thickness radically from AP to lateral. Okay? And so you should be dialing up the lateral hand technique. And it should be bumping the kilovoltage up, because you're not going through just 1 inches of flesh. You're going through 3 inches of flesh now through the metacarpal bones. Okay. Soft tissue imaging. What's the region of interest? A cervical spine technique and a soft tissue neck technique are not the same. Okay. The soft tissue neck technique, you can bottom out the KVP. You can drop the KVP to like the high 60s for soft tissue necks. The centering's the same. Okay. But if you're evaluating the bony anatomy, you need more penetration. Okay. And so you need to go 75 to 80 for a cervical spine. But if it's the windpipe that is the area of interest, that's an air-filled structure surrounded by soft tissue. You don't need 80. You only need 66, 68. Okay. And then finally, contrast media. Abdomen, shooting a plain KUB, you're going to do what, like 85 at 12? Okay. But if the patient has drank about a quart of barium about 45 minutes ago, you know that the barium is going to be attenuating that x-ray beam. And so you're going to need more of both. Probably. You're definitely going to need more penetration power, because the barium effectively adds thickness to the tissue. Okay? And you're going to need more mass because the barium is absorbing more of the photons. And so it's attenuating. more. Once the patient has drank the barium for the small bowel follow-through, you can't use a conventional abdomen technique. You have to boost the KVP and the mass for small bowel follow-through. Okay, automatic exposure controls. All right, and that's everyone's familiar with the Mickey Mouse ears. All right, and so I did teach you these. Now in chapter, I think it was chapter 6 of Bouchon, he briefly mentions the various types of timers. Synchronous timers are obsolete. We don't use synchronous timers anymore. A synchronous timer was basically a motor that spun at 60 hertz. And so that's 60 cycles a second. So you can actually keep time with this motor. Okay. And so every 60 revolutions of the motor was 1 more second. Okay. Early watchmakers used synchronous motors. Okay. Electronic timers, that's your quartz timer, that's your kitchen countertop timer, or the one in the control panel for your modern oven. Okay. Or your stove. Some of your stovetops might have timers now too. Okay, your microwave timer is an electronic timer. This is based on it's a circuit board that's they're passing a specific voltage through a quartz wafer, and the quartz wafer is vibrating at a certain frequency. Okay, it's called the piezoelectric effect. We're going to talk about it in ultrasound, but that frequency, remember, that's cycles per second. And so that's a known property of quartz, and we know, like, if we pass 3 volts through, we know we're going to get a certain frequency. Okay, so that's what we'll do. And then by measuring that frequency that the quartz is actually vibrating at, and knowing what it's supposed to be, we can use that vibrating crystal to keep track of time by measuring the vibrations and the frequency of the vibrations. Okay. All right. Your mass timers used for falling load and capacitor discharge imaging systems. Your mass timers are basically a software subroutine that couples with the electronic timer, but cycles the rheostat and cycles the discharge of the capacitors. So it's extra software instructions as the exposure is continuing. Okay, and then finally, automatic exposure control is the one that we're going to dive into deep here over the next few slides. Okay, now your techs will call those phototimers. Why the heck will they call those phototimers? Because the first iteration of the technology involved a photostimulable screen and a photomultiplier tube. So it was shortened into a phototimer system. Okay, your modern AECs are not phototimers at all, they're ion chambers. Okay, so phototimer is an archaic word. The first iteration of the technology had a fluorescent screen behind the image receptor, so the X-ray beam penetrated through the patient. Some of it was caught by the image receptor, some of it passed through the image receptor and hit this fluorescent screen. The fluorescent screen glowed, and then that light was picked up by a photomultiplier tube, which amplifies and converts to electrons, and that electron, I'll pause, hang on. Okay, so the photomultiplier tube amplified the light photons and converted them to electrons, and then those electron outputs of the photomultiplier tube was the electric current that shut off the exposure. Okay, your modern AECs typically use ion chamber systems rather than phototimer technology. Phototimer technology is flawed and it's not as efficient as an ion chamber system. Okay.
Yeah, it's NGH, School of Health Sciences.
So,
on the application fee.
All right, and so our gas ion chamber is just it's a piece of plastic, like clamshell plastic, you know, those annoying containers that you have to open with a box cutter or a pair of scissors. Yeah, picture something like that, where it's just like a rectangular, rounded corner rectangular prism of plastic. It's got a volume of air in it, probably nitrogen, because that's cheap and abundant. Okay, really doesn't matter what kind of air is within there. We'd like it to be moisture free so that it doesn't rust out. But just a little quantity of air, so like some nitrogen inside a little plastic case, if you will, sealed up. And then there's a cathode and an anode at either end of the air space inside the plastic case. Much like, so the little dots, those are the nitrogen atoms that you see there. And then you can see one of those is a positively charged little strip of wire or whatever, could be a plate. And the other one is negatively charged. So that's your cathode and your anode. Now, is the electricity going to jump across that? No, the nitrogen is acting as an insulator. Okay, and so there is a low voltage applied to this ion chamber, but the nitrogen is preventing the electrons from jumping across the air gap and going and jumping onto the anode. Okay, so you might say, this looks like a second cousin to the X-ray tube is tilting. Yeah, it's got all the component parts except for we've put air in the way. So the electrons don't jump across spontaneously. The valence electrons of the nitrogen are actually repelling those electrons on the anode, so that even though they're feeling the pull, they're being repulsed by the insulating effect of the nitrogen. Okay. So the ion chambers are thin, flat rectangles. There's a little bit of air trapped in between. It is sheets of plexiglass. You don't mount them the same as you mount, see, over on the left-hand side, that's the phototimer. That's how we used to do it, okay? But that's problematic because you have to use way too much kV to make sure some of the photons pass all the way through the patient and all the way through the image receptor. And so that's why that's the fundamental flaw. Okay, with an ion chamber system, we can put the ion chamber in front of the image receptor, between the patient and the image receptor. Okay, the ion chamber is basically radiolucent. Okay, because it's primarily made out of plexiglass. Okay, and so the X-rays can penetrate through. The remnant beam can ionize the air in the little plastic box, but not enough of the remnant beam is stolen to affect the quality of the image. Okay. Now, most AEC systems are operating with about 3 AECs arranged in a triad, like a triangle arrangement. You have the 2 outer cells and then a center cell. The center cell is basically at the center of the image receptor or the Bucky tray, either in the wall or inside the table. Modern units can have up to 5 ion chambers, so you could have almost like a dice face, you know, like a 6-sided die. Look at the number 5. That would be the arrangement of the ion chambers. Okay. Most of your older systems are just the standard 3 ion chambers, 2 outer ones and then a middle one. Okay. So the thing about AECs, we're using it for automatic timing, but it's not actually measuring time. It's measuring the accumulation of ionization, which is an indirect way to measure remnant beam signal strength. And so when the ion chamber catches enough radiation, the nitrogen is going to ionize, and then it's going to allow those electrons to jump through, because ionized air can conduct electricity. Okay, because we've liberated, there's vacancies in the valence shell, there's positive ions and negative ions. So when those nitrogen get hit by the X-ray photons and a photoelectric event occurs, you're going to end up with positive nitrogen atoms that have valence shell vacancies. And now basically the electrons can bunny hop or leapfrog across those positive ions and eventually deposit themselves across the cathode on the other side of the ion, onto the cathode on the other side of the ion chamber. When that happens, you do that enough times over and over and over again, and what you're doing is you're conducting an electric current across the ion chamber. Okay? Now, that's all dependent upon remnant beam photons actually entering the ion chamber and ionizing the air. And so we got some trouble with that, okay? Because when part thickness changes or a larger patient is radiographed, we know that attenuation increases. And so therefore the remnant beam strength, that is the number of photons coming out of a thicker patient, is reduced if we don't make any changes. All right? And so if the remnant beam is less intense, less photons in it, the ion chamber is not going to achieve ionization, and therefore electricity is not going to pass across it, and therefore the circuit is not going to be shut off. And so the exposure is going to keep running. Okay? And that's the fundamental flaw with ion chambers. Thicker body parts run longer exposures, necessarily, because you're counting ionizations from the remnant beam, and thicker body parts absorb more and therefore thin out the remnant beam. So it's going to take longer for what we call threshold ionization to achieve conduction from cathode to anode. Okay, it's going to take longer for that process to occur, so your exposure is going to run longer. Okay, you still need to set optimal MA and KVP, especially optimal KVP, because adequate penetration is what's preserving that remnant beam signal strength in the case of thicker body parts. Okay, if your KVP underpenetrates, your AEC is basically going to be disabled. It's not going to work right because your remnant beam is going to be so thin that it's not creating enough ionizations in the chamber. Okay? Your density control, which lets it basically adjusts the voltage to the ion chamber and makes it more sensitive with higher voltage or less sensitive with lower voltage, is not effective on beam penetration. The density button on the AEC only controls the sensitivity of the ionization chamber. Is ionization easier to achieve because we have a higher voltage between cathode and anode, right? That is a charge difference effectively. Or is ionization threshold harder to achieve because we have a lower voltage running, lower voltage difference, lower charge difference between cathode and anode. Okay, remember, it's the voltage is like the sum of the Coulomb forces, and so a higher voltage, that electron is feeling the pole stronger, so to speak, and so is it's more rapidly motivated to jump across the chamber. A lower voltage setting, that is a density minus setting, is going to reduce the difference in the charges stacked on the cathode and anode, right? And so the sum of the Coulomb forces is going to be reduced, and then the electrons are not as motivated to jump, and they don't respond as rapidly, and therefore threshold ionization is harder to achieve, and the exposure runs longer, okay, with a density plus button versus a density minus button. Okay. Now, if you don't wrap your head around density plus and density minus, remember I said it's antagonized by automatic rescaling, and I'm going to get to that in a second. One of the key considerations with AEC is the minimum response time. The modern AEC circuit is controlled by a transistor. And the transistor is kind of like an automatic switch. It flips open or closed, it turns circuits on or off. But there's a problem. Those switches are not exactly instantaneous. The fastest we can get those switches to run is 2/100ths of a second. Those automatic switches. That's pretty close to instantaneous. But when we're talking about really short exposure times that are like 2/100ths of a second long, that's 1/10 of the exposure time. And so when your exposure times are really, really low, like in the hundredths of a second range, okay, the AEC loses its ability to deliver an optimal exposure time. So a special consideration for pediatric patients. Your exposure terminates so quickly that the transistor in the AEC circuit can't respond fast enough, and you're actually overexposing your patient. Okay, and so like an example, like a pediatric hand, okay, you could get away with like 0.6 mass, but your minimum response time for your AEC is like 0.8 mass or 1.2 mass. Okay, and so that's either like 40% more than you need or double what you need. Okay, and so you're necessarily overexposing the tissue. And so the reaction time of the AEC circuit for very, very rapid exposures, the AEC is not recommended because it can't turn off the circuit. It can't terminate the exposure fast enough. The transistor has lag. Okay, it takes time for the transistor to cut the exposure. Our backup mass. So you noticing we're having trouble with extreme thicknesses. AEC breaks down and is not adequate, can't respond fast enough for very thin or very small body parts, and so you end up overexposing. AEC cannot gather enough remnant radiation with larger body parts. And so we end up having to set a backup mass. So every AEC software, you might notice that it says AEC engaged, but then it also has like 400 or 600. What does that mean? That means if the chamber fails to capture enough photons and the exposure keeps running and keeps running, and it doesn't trigger a termination of the exposure in the ion chamber, the machine's going to automatically kill the exposure when the backup mass or the backup time is reached. Okay, and now in general, your backup mass, your backup time should be no more than twice what you expect to use. So even when you're using AEC, you should have an idea what you expect the mass to read out at. Okay, and like I said in the first year, pay attention to what that mass readout is. Okay, it should make sense to you. Like a PA chest, you should be achieving with 120 kVp. You should be achieving like a mass readout of like 2.5, anywhere like 2.5 to about 6 for hypersthenic, maybe up to 10 for hypersthenic. If you're going longer than that, that's because you got a 350-pound patient and your AECs are not actually tripping off. You're running into the backup time is what's happening. Okay, and so pay attention to the backup time. Sometimes the pre-programmed backup time is 4 or 5 times what you need. And so you can adjust that. You can scale that down. That's one of the adjustments you can make. So if you have a hypersthenic patient, it doesn't mean that you can't use AECs. It just means understand that the AEC might not achieve threshold ionization because the patient's absorbing all the X-ray, and there is no X-ray. There's not enough X-ray intersecting the ion chamber. So it never turns off, it never terminates the exposure, and you run into the backup timer. So you should be aware of that scenario. That's a very common scenario with your hypersthenic patient. Okay, and so the density plus and density minus buttons that I covered just a little bit ago, those were designed for screen film technology, and they actually did affect the overall darkness or brightness of the image. That's why they're called the density buttons. Okay, unfortunately for us, the overall brightness or darkness of the image is no longer affected by our technique, not our mass and not our density buttons on the AEC. So what did the density buttons do? Well, like I explained before, the density buttons change the sensitivity of the ion chamber, so it's easier to achieve threshold ionization, right? That would be the negative numbers, and therefore your exposure is going to trip earlier, or it's harder to reach threshold ionization, and then the exposure is going to run longer. Typically, each step, like going from no change in the density button to a -1, is a 25% increase or decrease in the mass, the overall exposure time, the effective remnant beam signal strength. Okay? The problem is we now have and the first bullet point mentions a thiatron. That's part of the AEC circuit. It's mentioned in the other text. It's not mentioned in Bouchon. But the problem is we now have a software that the software controls the overall darkness and brightness of the displayed image. It's got nothing to do with technique anymore. So effectively, not only is the density button a little bit obsolete, the density button is also antagonized by one of the image processing softwares. So let me tell you about rescaling. So you send a remnant beam and it's caught by your image receptor, and that turns into an intensity recorded in the pixels. And then you got about 1 million pixels in the matrix that are sent to your software to start processing and turning into an image. The more intensity a pixel records, the more photons hit it, therefore the darker color we need to display on the monitor. And that's basically how the software works in a nutshell. It measures the intensity, it assigns a grayscale color based on the intensity relative to the other intensities you recorded, and then it populates colors of pixels on the monitor according to how much radiation was caught in this area according to the raw data from the detector. Okay, so let's say it's expecting each pixel to catch between 100 and 400 X-ray photons. Okay, and so it's anticipating that, and it can assign the 100. If it only catches 100 X-ray photons, that's going to be bright white. If it catches 400 X-ray photons, that's going to be black. But you send it intensities that range from 400 to 1600 photon strikes per pixel, which, if you can't do the math, that's 4 times the exposure necessary. 4 times the intensities that the software was expecting. Should it paint all the pixels black? Because according to the rules, anything that has more than 400 photons should be painted black, according to the rules we defined in the software in the first place. But that would mean that we painted, for your data set, all the pixels black. Are you going to have an image of anatomy there? No, you're just going to have a black computer screen. And so the software says, these are not the pixel values I expected. How about if I divide all the pixel values by 4? So it recognizes that geometric pattern. You have overexposed intensities by a factor of 4, and so it scales those intensities down by dividing all those pixel intensity values in the data by all the intensity numbers by 4. And then lo and behold, now all the values are between 100 and 400, and now it knows how to assign the colors. Yeah, it's glorified paint by numbers. Yeah, that's it. That's it. It is paint by numbers. Okay. So it can also, it can scale down, which is more common, but it can also scale up to a certain extent. Okay. And so if you underexposed and your pixel values are, say, like 50 to 200, then it's going to multiply your intensities by 2 and then bring them up into the appropriate scale. So let's go back to that density button. In density plus, the ion chamber is going to be less sensitive. It's going to take longer to achieve threshold ionization. The exposure is going to run longer, and therefore more remnant beam is going to hit the image receptor. And you're going to have higher pixel intensities. And then that raw data is going to hit this software. And if those intensities are out of the expected range, the automatic rescaling software, when you hit the density plus button, you scaled up the intensities, this software is going to scale those intensities back down. And so what really happened with the density plus? Well, you ran the exposure longer. And so what does that mean? Did you change anything about no, the computer corrected for it. It literally reversed the change that you made when you selected density plus. So the only thing you did was ran the exposure longer, which means longer mass, which means you dose your patient more. Okay? And if it's scaling your intensities down, it's also going to tell you that you overexposed your patient. So that's really all the density plus button is doing for you in the monitor. It's not changing the brightness or darkness of your image. That's controlled by the software. Okay. In fact, one of the softwares is in an antagonistic effect to adjusting density. Okay. And so my advice to you, I'm required to teach you the density buttons, but my ultimate advice to you that you don't see in the books is rescaling software makes density buttons obsolete, absolutely obsolete. So your AEC needs to be calibrated correctly, and I recommend you don't change the density button to try to change the remnant beam signal strength. If your remnant beam signal strength is poor, instead of using density plus, increase your kilovoltage when you shoot again. That's a better adjustment in the digital era. Mr. Till's an exclusive there. You won't find that in any of the textbooks. I figured that stuff out on my own, and I wrote a question to Appleton and Lang revealing that concept, and they did put it in their review book. Okay. So rescaling corrects. So in screen film, as you see in the top 3, you can underexpose, that's the far left one. You can adequately expose, that's the middle one. Or you can overexpose, that's the far right one. And the rescaling software will correct those intensities to the expected intensity, which is adequate exposure. Right? And so it automatically corrects, the software corrects your brightness and contrast for you, regardless of whether you have optimal technique or slightly off technique. Okay. So again, I've already explained it all, but again, density plus adjustments only cause exposures to run longer, increase patient dose. Density minus adjustments terminate the exposure prematurely, and then you're risking underexposure and the presence of quantum model. Okay. And so again, that's how the density buttons work. They adjust the sensitivity of the ion chamber, but you really shouldn't be using them because the software is going to try to correct your changes. Okay. Your limitations of your AEC. What can your AEC do? What can your AEC not do? Well, your AEC is not intended to be used for all procedures. Your AEC is only useful when the anatomy of interest is actually bigger than the active cell. Okay, so a lung, yeah, that's bigger than a 2 by 3 inch square. And so you can use AECs for lungs. Sure, that works. The spine, yeah, you can use the center cell for a spine. Abdomen, yeah, an abdomen is bigger than an active ion chamber. Finger, hold up. The ion chamber threshold, again, let's go back. How does that trigger? It achieves threshold ionization such that those electrons can jump across the chamber. Okay, that threshold ionization is achieved because the correct number of photons have ionized the correct number of nitrogen atoms, that we can get a leapfrog effect. Okay, it's calibrated to remnant beam signal strength. So if you put a finger in front of an active AEC chamber, primary beam, it's not going to completely cover that active chamber, and primary beam strength or intensity is going to enter the ion chamber, which is about 1,000 times greater than remnant beam signal strength. Your exposure is going to trip way prematurely for primary beam intersection of the active chamber. Okay, so so if photons enter the chamber quicker than expected, like primary beam hits the active chamber or too much scatter radiation hits the chamber, the AEC can trip prematurely. Okay, when the AEC achieves threshold ionization, it shuts off. Now, was the threshold ionization achieved based on measurement of remnant beam signal strength? I don't know. Did you cover up the entire ion chamber with the body part? Or was it achieved because some of the primary radiation hit the ion chamber? Okay, in the latter case, you've probably underexposed the part. You're going to have model. So body parts that don't adequately cover these chambers probably shouldn't utilize AEC. Notable examples are the clavicle, the mandible, a lateral sternum projection, and a lateral scapular Y projection. Now, some people can do center cell scapular Y, and it looks pretty. Okay, I did that in my day. I was able to do center cell scapular Y. Okay, it really depends on your position. Do you have that deltoid muscle centered to and covering the AEC? Okay, remember your asthenic cavitis, your sweet little old lady. She doesn't have a deltoid muscle, not like a power forward does, not like an X-ray tech does. Okay, so consider that. Do they have enough tissue in front of the active ion chamber to actually thin out the beam? Because the ion chamber is calibrated to the strength of the remnant beam. And so if it gets any of the primary beam, or if the body part is too small to cover the entire chamber, or the shape of the body part doesn't lend itself to covering the entire chamber, like a flat bone, then you probably should manual technique, because you're going to get underexposure if you don't. Okay. With AEC techniques, positioning is got to be more exact than it will be for manual techniques. So you know, with a digital detector, you've probably figured out by now you don't have to put the hand in the center of the DR plate. You can put it over in the corner of the DR plate and it works just fine. Well, that's because it's a manual technique and you're not using an AEC. Okay? But if you're off center to the image receptor, like a shoulder, but you're off center, it is going to make a difference. Okay? And typically, off center errors means that the chamber might still be covered, but it's covered by thinner tissue than what's supposed to be at the center of the field. Okay? Because body parts do taper as you get away from their centers. Like knees, any of the extremities taper on the edges rather than through the center. The thickest part of the knee is right through the kneecap. On the edge of the knee, it's technically thinner than going through the kneecap. Okay? The second thing is you want good collimation. If you got a lot of raw primary beam hitting the image receptor, then expect your exposure to terminate prematurely. If you're not collimated down, I say this on this, it's the swimmers all the time. The reason the swimmers doesn't look good, most of the time you guys see it in clinical education, is because the techs don't collimate it. You don't shoot a 14 by 17 exposure field or a 17 by 17 exposure field for a swimmer's projection. At the very least, you collimate anterior to posterior. I get it, the radiologist wants to count down from C1. He wants to clear the whole thing. Fine. We can open up the collimation to the base of the skull. I'm cool with that. It's really about visualizing C7T1, but if you want to visualize the whole spine, that's your prerogative as a radiologist, and we can open a collimation top to bottom. But you should be collimating anterior to posterior. So if you're opening it up so that you have the entire scapula and the entire sternum on your swimmers, expect to be generating a lot of scatter radiation. That scatter radiation is contributing to the ionization in the chamber, and your exposure is terminating prematurely because you don't know how to collimate. Clutch the pearls, ladies and gentlemen. Yeah, collimation matters, right? You're going to get modeled, washed out swimmer's projections because you're doing it with AEC and you're not collimating, and you're generating way too much scatter, and the scatter is contributing to threshold ionization, and it's prematurely terminating your exposure. And so you've got excess scatter plus noise added to your image. That's why your swimmers looks like garbage. Shoot the same thing, collimate it down to, you can collimate a swimmers down to a 6x6 centered at C7T1, and it's going to look a million times better. Well, maybe not a million, I might be bragging there. Okay, but it's definitely going to look better than a non-collimated swimmers. Okay. On the flip side of that, versus raw primary, if there is an unexpected attenuator, like a metal prosthetic, I'm talking about hip replacements, okay? That big chunk of metal is going to absorb all the X-ray inside the patient, and none of the photons are going to get through that big prosthetic chunk of metal to reach your ion chamber. And so threshold ionization is not going to be achieved, and your exposure is going to run long. Okay? And so the authors agree when there's a prosthetic in front of the ion chamber. How do you figure that out? I don't know, maybe take a patient history. Clutch the pearls again, ladies and gentlemen. Yes, ask your patient. You're doing a hip x-ray? Less probable, but doing a shoulder x-ray? Yeah, they can have a shoulder pin too. I've seen them. Okay. But an artificial hip is not that rare. All right. So patients of a certain age, if your patient's under 30, I wouldn't bother asking. But if your patient's over 30, yeah, have you ever had a hip surgery or a hip replacement? If your patient's geriatric, you better be asking, because you know you can't use AEC on that hip series. The exposure's gonna run long and you're gonna overexpose. Okay? Yes, it's gonna scale down, it's gonna try to make it look pretty, but you can do better. You can save patient dose. Okay? So manual technique, the prosthetic hip. Okay? So with a prosthetic, if the prosthetic covers the entire chamber, you'll run to the backup timer, okay, which is supposed to be only 2 times what you expect. If you've checked to make sure it's only 2 times so what do you expect for a hip? Like 80 at 12. So the backup timer should be about 24 mass, okay? But what if the backup response time is 100 mass? Well, then you've overdosed them by 5 times. Okay? Don't do that. Manual technique it. Don't let that thing run to the backup timer. If your AEC is running to the backup timer and you're using the AEC wrong, then you should be manual techniquing. Okay. Detector cell configuration and or placement. So you can see, and again, this is from the Carroll book. Some of the Bouchon, to be honest with you, doesn't do an adequate job, right? And so I'm carrying over some of the points that Mr. Carroll made from his book. Even though you guys don't have access to the textbook, you still have access through it vicariously through this PowerPoint. So we can see that the active cell, we're trying to do a hip, but the black arrow is showing us where the hip actually is. We've got part of the lesser trochanter and shaft. Yeah, that's diaphysis. And then soft tissue, okay? Whereas if we had centered to the actual femoral head, then we would have the, the acetabulum collar, that hip socket, plus the entire thickness of the femoral head, and then also the patient's soft tissue in their buttock that would be attenuating the radiation better than this is. And so does it look underpenetrated, right, and underexposed? Can you see the acetabulum? Very, very faintly. You got to turn off all the lights in the room as you're viewing this and squint really hard, and then you can barely see the outline of the femoral head there, right? And so it looks like it's inadequately penetrated. The reality is it prematurely terminated the exposure because it wasn't centered appropriately, okay? And so the active chamber is over top of thinner tissue rather than the thicker tissue, which also happens to coincide with the anatomy of interest. And so the recommendation when you're, again, positioning is this critical? It really is. It's got to be, your positioning is going to be on point for AEC exposures, okay? And when in doubt, center the thickest part right over that active chamber. And that's how you're going to ensure adequate penetration, and you're going to avoid prematurely turning off that exposure and underpenetrating, underexposing. Okay. All right, so your exposure indicator is going to run high or low. If your exposure indicator runs in what the manufacturer recommends, well, then you don't have to problem solve. But if it runs high, you should run through this checklist. Did you activate the cell? Now this one has been corrected by software by and large in the modern era. You activated the table bucky ion chambers, but you're shooting a chest x-ray at the wall, okay? Manufacturers figured out that we were doing that, and now the APR can recognize, right? It's like, okay, you have selected PA chest at the wall, but you have that x-ray tube pointing toward the table. So I'm disabling the exposure until you get your head together and actually aim the x-ray tube at the wall. Okay, and so that's largely been avoided by software and safety protocols encoded into the operation system of our modern x-ray tube. Needed exposure less than minimum response time. Okay, so this is your small body parts, your pediatric anatomy. In general, pediatric techniques, you really shouldn't be using AECs because the default AEC is calibrated for adult habitus, not pediatric habitus, okay? Unless you're at a dedicated children's hospital, and then the AECs will probably be calibrated for like an 8-year-old, okay? And then you scale them down for your infants and toddlers, you scale them up for your adolescents, okay? Your density control was adjusted to the plus setting. Then your exposure is going to run long, and your brightness and contrast and your pixel intensities is going to be rescaled, but it's still going to send you a high exposure index, trying to tell you, hey, you overexposed. Okay. Your backup timer activates. Remember, the backup timer is a safety shut off, so you don't just keep exposing in perpetuity for those thicker body parts, those thicker patients, okay? And so it's going to turn the machine off when the ion chamber fails to activate. Incorrect cells activated. You've probably done this one, okay? You're doing a PA chest, it's outer cells, right? And then you autopilot right into lateral chest. Did you switch to the center cell? Oops, that exposure was really quick. That was like ridiculously quick. Yeah, that's because you had the outer cells activated and you had a skinny patient, and some of the outer cells were actually outside of the sternum. And so the exposure terminated too fast, and you actually underexposed the lateral because you kept the outer cells activated. Okay, happens to all of us. Been there, done that. Okay, so be mindful when you're switching from AP to lateral, especially in that chest X-ray. That's when it most commonly happens. Switch to the center cell on the lateral. Okay. Prosthetic hardware. Did you ask? Because I just told you, just 5 minutes ago, I told you to ask. Okay. If they got an artificial hip and you AEC it, and it looks like all the soft tissue is burnt out, you can see the prosthetic. That's a nice white color, right? But you can't see the acetabulum, you can't see any of the pelvis, you can't see any bowel gas. The rest of the image is just like a dark charcoal gray. Yeah, that's on you. That's overexposure. Okay, you shouldn't have run it with a prosthetic hip. You should have asked if the patient had a prosthetic hip, and you should have known not to use the AEC if they had a total hip replacement. Lead aprons or sandbags obscure the active cells. Again, this is the large attenuator covering up the ion chamber. So a lead apron is definitely an attenuator. That's how shielding works. Okay, it absorbs the X-ray. That's what we want it to do. We want the lead to absorb the X-ray so your reproductive organs, or the patient's reproductive organs, don't absorb X-ray. Okay, and so that means your ion chamber isn't going to absorb X-ray either if it's covered by the lead apron. Now look, if your lead apron is covering an active ion chamber, you are doing shielding wrong. Okay? Because I know that the anatomy of interest, those ion chambers are very close to the center of the image receptor. What the heck are you doing putting a lead apron in the center of your field of view. You don't do that. You put the lead apron at the edge of your field of view. Shouldn't be anywhere near the ion chamber. Same thing for using a sandbag for immobilization. Shouldn't be anywhere near your pertinent anatomy. You can immobilize a wrist at the elbow with a sandbag. You know, you got a screaming 2-year-old, right? Dad is doing his part. He's sitting in the chair. You got the screaming, thrashing 2-year-old on his lap, and he's giving him the bear hug, you know, the super bear hug, locking him down. But it's up to you to hold the arm still. Not you, because you're the student. You're not allowed to hold, right? And you sandbag. Do you have to sandbag like right outside the wrist? No, sandbag all the way back at the elbow. You'll actually find that that's more effective for control, to keeping the wrists still. Okay. Yeah, the smaller the body weight for your pediatric patients, the more effective sandbagging. Yeah, sandbagging, literally, it's literally slang for hijacking someone's process, getting it, interrupting their task, you know, trying to impede what they're trying to do. And it's literally an immobilization technique in X-ray. Okay, what is your 2-year-old patient trying to do? They're trying to thrash and wrestle and get the hell away and escape. If you let them go, you know where they're heading? They're going toward that exam room door. Don't you dare let them get out the exam room, because I hope you're a jogger for your exercise, because if you let the 2-year-old out of the exam room, if they get loose of you or the parent, oh my God, you're going to be chasing a 2-year-old through the hospital. Oh my God. Okay, back to the lecture at hand. We only got 4 more slides to go. Okay. So your checklist, your troubleshooting checklist, when your exposure indicator is too low, indicating that the AEC turned off too rapidly. Your backup timer is set too low. Now again, that's bad, because again, what I say is you shouldn't be reaching your backup timer, okay? Ever. You really shouldn't, okay? It should be about 2 times the mass you expect. And even with hypersthenic patients, you should be achieving threshold ionization and not running into the backup timer. Your density control is left on the minus setting. Okay, again, check that. Again, in the digital age, the density controls don't really make much sense. They were for adjusting the brightness, and exposure time was proportional to the overall darkening of the film. Okay, it doesn't do that anymore. It only makes your exposure time run long or run short, and that's usually going to be corrected by the processing software. So again, my advice, understand what the density buttons do, and then also understand they're obsolete in the digital age. Inadequate collimation. Looking at you, swimmer's X-ray. Okay, look at all the raw radiation anterior to the patient here. You have the entire sternum. I guess that's a bonus evaluation here for our swimmers. Okay, you've got half a skull. You got a good lateral facial bones here. Okay, so bonus read incidental findings for the radiologist here. But if this is supposed to be swimmer's collimation, yeah, you failed. You have failed to the point of negligence. You got a nice, so you have half a skull. You got a nice lateral facial bones. Okay, you got a humerus there, partially superimposed by the cervical spine, but you got a humerus there. Elevated side humerus can be read. You got half a T-spine here. You got a lateral sternum here. All of this, and you got a soft tissue neck. Okay? Your area of interest is C7T1, not the frontal sinus. If your frontal sinus is showing, or your patient's frontal sinus is showing up on your swimmers, you don't know how to collimate. I can't believe I have to say this. All right. Incorrect cells activated. I mentioned that previously. Your exposure for your lateral chest, now that's the most common one. Lateral chest x-ray forgot to change to center cell. Man, that exposure was quick. Why does it look like a white silhouette on a black? Yeah, because the exposure terminated so quick you didn't penetrate any of the anatomy. Okay? Yeah. Anatomy too small. You can't use AECs on fingers. In fact, anything below the shoulder, you shouldn't be using. Humerus, you shouldn't be using AEC. Okay? It's too small. It doesn't cover the ion chamber. Okay? So anything below the shoulder, do not use AECs. Anything below, you can use AECs in the lower extremity. I think you can get away with it in the knee. Center cell, most people's knees do cover the center cell. Okay? Anything below the knee, manual technique. Pediatric patient, when in doubt, manual technique. Okay? Body part small, doesn't completely cover the chamber. You really can't use AEC. It kind of disables the mechanism. The AEC is calibrated to the strength of the remnant beam. It's trying to assess the strength of the remnant beam. Okay? If you hit it with primary radiation, it's going to prematurely terminate the exposure, and you're going to have an underexposed image. AEC technique charts. If you go to the trouble of making the technique chart, you still need adequate penetration. Okay, you should, now it says optimal MA, to consider minimum response time. So the MA has to be small enough so that the exposure time, the minimum response time, is not competing with the total exposure time. As soon as the minimum response time is like 1/10 of the total exposure time, you really should be converting to a manual technique. Okay, focal spot size should not be ignored when you're using AEC. Okay, you should be using a large focal spot size through the torso. Okay, probability of patient motion. If that exposure, like your hypersthenic patient, here's another downfall for your hypersthenic patient. Your hypersthenic patient, thicker body part, so we know the exposure is going to run long. We compensate with an increase in KVE, but that AEC still runs long and the exposure runs long. What's our risk? Yeah, motioning. Okay, so what I have found anecdotally, you can still use AECs for hypersthenic patients, but the exposure time runs long and the probability that the patient's going to move and you're going to have motion artifacts increases. Okay, it just necessarily does. That happens every time exposure time increases. Okay, heat load to the X-ray tube. Again, flashbacks to physics. What was the heat units formula? It was KVP times MA times time times 1.4 for the modern generators. Okay, that was, so for single phase, it's just the first 3 terms. But if we're using 3-phase, 6-pulse, 12-pulse, or high-frequency generators, which that's all modern X-ray equipment, we're going to multiply the heat units formula by 1.4 for the increased efficiency in the generators. Okay. When your AEC runs long, understand your heat units are going to run long or get bigger. Okay. And so you might chew up available heat also with that hypersthenic patient. So if you got a 350-pound patient and you're trying to do a lumbar spine, okay, understand that when your exposures run long using AEC, that you might achieve maximum heat units halfway through the series, and you might have to stop and wait for the tube to cool down. Okay. It says small focal spots should be used for extremities. Again, I'm going to recommend do not use AEC past the shoulder in the upper extremity. So humerus down to the fingertips, you should be manual techniquing those. For the lower extremity, you can get away with using the center cell through the hip, through the femur, properly centered, and through the knee. But below the knee, you should be manually technique. So tib fib, through the ankle, through the foot, manual techniques. Okay. Proper detector cell configuration must be selected. Appropriate backup time should be double checked. Okay. Now, APR. And the modern textbooks have really done a disservice to APR because APR are the technique charts of the modern era. They are effectively modern technique charts. And the manufacturers have done us a solid. We don't have to develop them. Do we have to check them? Do we have to verify them? Do we have to use them? And then like question them when they're, it's like, okay, this is what it says. And then you press the button and it's like, well, that looks like garbage. That looks radically underexposed. What was the mass? 2.5 mass? That's not enough mass. Now this is a rarity, but this could happen. Okay? So 2.5 mass for a hip, right? I don't know. There might be a machine out there that's capable of shooting a hip at 2.5 mass, but I doubt it. Okay? I'm thinking like 6 to 8, maybe 10. Okay? So dial up your pre-programmed technique. The modern ones, 75% of the time or greater. That's pretty accurate. Adjust it for habitus, right? There should be a button on there. You should see silhouettes. Big patient, little patient, average size patient. Make that adjustment. Watch the technique change. Okay? Okay? The default setting is thennic habitus. Okay? Interview your patient. Take a quick history. Do they have emphysema? Do they have additive or destructive pathology? If you don't know what those are, Ms. Smith is going to teach you pathology starting in January. Okay? And so you're going to learn what those additive and destructive pathologies. Scale your technique pack for the destructive pathologies. Boost your technique from the recommended for those additive pathologies. Okay? That's what those things mean, right? Okay? APRs, the pre-programmed software techniques, can and should be overridden by prudent, reasonable judgment by a technologist. If the technologist says, that don't look right, we should change that, well then, yeah, you should change that, okay? And not only that, but the technologist should be proficient in that type of judgment. They shouldn't say, well, so when you say, is this appropriate technique? The technologist shouldn't like shrug their shoulders and say, I don't know, what did the machine say? That shouldn't be a thing. The technologist should be able to say, oh, phone ringy dingy, hang on. The technologist should be able to say, yeah, that looks like an appropriate technique, or no, that looks like a little bit too much, or a little, yes, or not enough. We should change that. Okay, so that judgment is not only the right of the technologist, but it's also the responsibility. Okay, the accuracy of the techniques vary by manufacturer. Like the Canon system, that's spot on. The GE, I've worked with the GE Digital, the default GE techniques. Those are rock solid. 95% of the time, those are working. Provided over the phone. Okay. I don't know who that person is. Let me look. Okay. Let me see if I can figure that out. Other software systems, to be honest with you, I haven't worked with a lot. I've worked with the Canon image receptor system and the Canon APR, and I've worked with the GE APR, and I can vouch for those systems. Other ones, I don't know. All right, you have to ask your technologist or start working with it and see if you like the quality you get. Okay. No, I've got it right here. And there's your APR system, and you can see, oh look, see the bottom row of buttons? Look, it's a silhouette of a man. What year did you say they graduated? Right there. So there's the exposure switch, and there's the master power button, and then the next button over is hypersthenic habitus. Look, and it's got 5 ranges. It's got 6 ranges. It's got all the way to baby. Okay? And look, in the buttons above, there's a silhouette of the head. Okay? And then the next one over, I can't make that. Oh, the one below that looks like a spine, and then that looks like a foot, and then that looks like an arm, and then that looks like a hand. Okay, and so I'm thinking these are body parts, these light blue buttons. Okay, right? So we got habitus buttons, we got light blue buttons for different body parts. Okay, that's your APR.
Give me just one second. I'll have to put you on hold.
Now sometimes it's this looks a little bit older. Sometimes it's a touch screen system where it's like you select chest and then it says ribs, chest PA, chest lateral, so on and so forth. And then you keep getting more specific with your selections, and then it ultimately recommends a technique to you. Okay, that's what I'm used to. That the Canon system is selection menu is like that. So is the GE selection menu. Okay, and so that's your APR. Your APR basically has taken the place of paper technique charts. Okay, but what about the little pocket notebook that y'all made us get, Mr. Tilton? Well, yeah, that's always your backup plan. You should always have it's like you wouldn't go up into an airplane without a parachute, would you? Right? So your APR, that's your airplane engine, right? You went up into the sky, it's gonna bring you back down safely. But your little pocket technique book that you've got stuffed in your pocket, that's when your APR fails you, and now you need a parachute. Okay, so yeah, each technologist should keep their own techniques, right? Regardless of what any APR says. All right, we made it through to the end. Hour and a half, not bad for 40 slides. All right, I will talk to you guys. We will meet in person for next week. But this week had to be recorded for senior breakfast. So y'all take care, and I'll see you next week.